Hello everyone, this is Sewaillem. I'd like to share with you the step-by-step approach for a uniportal large bullectomy. This is a 40-year-old male, morbid obese, around 39 in BMI, who's a smoker as well as bronchial asthma. He's been having on and off dyspnea, which he attributed to his obesity. Recently, he was admitted as a case of exacerbation of his bronchial asthma. Investigation showed a large apical bully taking almost the apical part of the right upper loop and causing compression. Uh, After controlling the bronchial asthma, and he was reevaluated and was consented for a bullectomy. He used the uniportal approach as standard for our procedures in the fifth intercostal space. As you can see, he's a bit obese with narrow intercostal spaces, which made it technically difficult, but we managed at the end. Of course, most of the time you'll find adhesions on the chest wall, which we witnessed on the posterior and anterior chest wall as well as apical. These adhesions were taken down. It took a few minutes just to mobilize the large apical bully. We also witnessed a multiple blips on the superior segment right lower lobe. Because of his morbid obesity and small intercostal spaces, we decided for initially just to rupture the bully. It will give us more space to work. As we rupture the bully, we can now appreciate more band adhesions here and there, and all these will be taken down in order to mobilize the upper loop and the bully and start our resection. Our last few adhesions found at the apex, and these were taken down. Uh, And at the end, we felt some resistance posteriorly, and there was this last band that needed to be taken down so we can mobilize the whole upper loop. Once that's done and the whole upper lobe now is freed from adhesions, we're assessing this bully. Actually, there were multiple bullies. The largest was seen on the CT, and this was the one. So, using reinforced staplers for very thin wall bullies, we started our transections, taking a very small amount of healthy lung. This was the biggest bully we've seen on the CT and clinically, and it took around 2 reloads to resect the whole thing, or probably 3 reloads to take out the whole thing. Once that's done, we're now tackling the superior segment multiple blebs using the same technique. You don't want to take too much tissues. If you have a reinforced stapler, you can take or resect the bully at its base or alignment with the normal healthy tissue. If you don't have reinforced stapler, you can take a small amount of healthy tissue and not resecting the bully itself. We found some also small bullies here and there that we elected to resect them as well. We wanted to remove as much as possible to make sure that, first of all, we don't have any air leak from these small blebs mimicking an air leak, and second of all, try to improve the expansion of the whole lung. These reinforced staplers are very helpful in pneumatic and pneumostasis and hemostasis of tissues, as shown in previous studies. These were along the basal segment of the lower loop, and like I mentioned, we wanted to remove as much bullies as possible. With minimum resection of normal healthy tissue. As seen, a small tissue was resected. which will affect the outcome. And by that, we concluded removal of all the obvious blips and bullies. Our next step is mechanical pleurodesis. Many ways have been discussed. Our approach is mechanical abrasion using a scratch pad on the anterior, lateral, and posterior surface of the parietal pleura. Just a quick look at the chest wall. There's no oozing extensively or major bleeding, and we'll just continue our final mechanical abrasion. And that concluded the procedure. Now we're checking for air leak by doing a saline air test. We irrigate the whole cavity with a lot of saline and will immerse the resection margins under the water and check for major or minor leaks. Of course, like I mentioned, these peristrips are excellent in pneumostatic and hemostatic materials, and we're just checking for mist or lung injury or any other site of air leak. I use a sponge on a stick and just immerse the lung below the fluid and check for air leak. As you can see, the lower and middle lobe expanded immediately. We're just checking the upper. It took a while for it to expand, but we're checking for air leak. You don't want to apply pressure hard on the lung. You may compress an air leak. So gentle pressure under the lung underwater and just checking for these major air leaks. Minor air leaks are negligible otherwise. And as we're inflating the lung, we're not seeing any major leak. This concluded the procedure. Now we're looking for the lung to fully expand after the multiple resections. Posterior segment of the upper lobe will be expanded soon, and all the fluid is suctioned out. So as you can see at the end, we're happy about our resections. There's no major or minor air leaks because of the peristrips. We're just waiting for the whole posterior segment of the upper lobe to expand fully, and that will conclude our surgery. As you can see, the whole upper loop inflated completely, filling the whole space. Of course, at the end, a chest tube was inserted. The patient actually did very well with the uniportal incision. Pain was controlled, and he was discharged on day 3 after surgery. Thank you for watching.